Professor Dr. Hamid Shatla, Dr. Hamid Al-Khayyat, Dr. Omar Rashidi, Dr. Huda Tmoum, Dr. Sahar Hassanin, and Dr. Raja Hussein. I'd like to first note that the deep brain stimulation for childhood onset primary dystonia is an important subject which is understudied in most of the times. And I will be starting with a little bit of history of dystonia. The term dystonia was coined by Professor Hermann Oppenheim, who is a German neurologist born in 1858 and died in 1919. In the year 1911, he described and named introduced the term dystonia to a group of patients, 4 patients who had the symptoms of dystonia. And since then, we are using up till now the term dystonia. But before Professor Oppenheim, we can see that the disease was there. We can see it in the sometimes in the paintings, even in the ancient times. We can see some paintings showing people who have some postures which might be patients with some dystonic disorders. Well, definition of dystonia is it was a dynamic thing. Actually, it has been evolving over the years and changing every decade or two. But this recent one describes dystonia and defines it as a movement disorder characterized by sustained or intermittent muscle contractions. The previous definition might be the only sustained muscle contractions. So in this new definition, sustained or intermittent muscle contractions causing abnormal, often repetitive movements, postures, or both. And dystonic movements are typically pattern twisting, and they added to the definition that it might be tremulous. Dystonia also is initiated or worsened by voluntary action, and it is associated with overflow muscle activation to other body parts. As the definition was evolving and changing over the years, so did the classification of dystonia. Dystonia classification has been also changing. In the 70s, scientists used to classify dystonia to primary, secondary, psychological. Then in the 80s to idiopathic and symptomatic. In the 90s, primary dystonia plus or heredodegenerative. 2004 into primary, secondary, complex, and acquired, and 2011 into primary, heredodegenerative, and secondary. The classification of dystonia, and so the thing with other movement disorders and other diseases is extremely useful in organizing our knowledge in order to guide us in better diagnostic testing and better understanding of prognosis of the diseases and putting or plotting management plans. This recent classification classified dystonia according or along 2 axes. The first one is the axis of clinical features, and the second one is according to the axis of etiology. According to the axis of clinical feature, whether according to the age, distribution, temporal pattern, associated features. The second axis, which is the axis of etiology, into dystonias with nervous system pathologies, heritable dystonias, inherited dystonias, or idiopathic. One of the problems with the previous classifications of dystonia is using the term primary dystonia. Sometimes it was used in the sense of that primary dystonia which does not have any identifiable cause, so it's primary versus secondary, or sometimes it was referred to as dystonia which is isolated dystonia, which does not have any other movement disorders accompanying dystonia. So it is dystonia, isolated dystonia versus dystonia plus. So in this classification, we do not have the term primary, and you can find it whether in inherited dystonias or in idiopathic dystonias. The treatment, of course, should start by medical treatment. Every patient with dystonia should receive a trial of levodopa, because the patients with dopa-responsive dystonia, as has been said in the previous lectures, that they improve very, very much. They show dramatic improvement on receiving the levodopa. Also, the anti-dopaminergic drugs, the anticholinergic drugs, and benzodiazepines and baclofen, whether baclofen oral or intrathecal. Botulinum toxin injection does not have that much role in patients with childhood onset dystonia, because when those patients start their movement disorders with the with the focal dystonia, they tend to generalize afterwards, and it's not practical that you can inject in all the muscle groups of this patient with generalized dystonia with botulinum toxins. Then the surgical interventions, DBS versus ablative procedures, and the peripheral procedure. So what is DBS? DBS is a device which is it is a device which is implanted into specific nuclei in the brain. Which nuclei? This is according to the disease, to the spectrum of clinical pictures. How does the DBS work? Well, we do know that it works, but how does it exactly work? We do not have that much knowledge, but there was theories that it did inhibit the abnormal signals. Another more recent theory that it stimulates the abnormal, under firing of certain nuclei, and then more recently it's thought of as it does resynchronize or re-rhythm the abnormal firing of different nuclei or structures. Well, the evidence of DBS for dystonia is there. It is evident. We have very, very strong evidence, class 1 evidence, that DBS is effective for patients with primary and segmental dystonias. In this study in the middle, they randomized 40 patients. They assigned them randomly whether to receive stimulation or sham stimulation. Sham stimulation means that they have the DBS in, but they do not turn it on. And they, after 3 months, they assess the response to both patients, whether whose device is turned on or not. And all the patients had very, very significant difference of the group of the patients with actual stimulation versus the sham stimulation. Scientists also was interested in describing the effect of deep brain stimulation in specific genetic forms of dystonia like DYT1. In this study, the authors described the effect of DBS in 7 patients with DYT1 dystonia, and there was significant improvements in all of those patients. Even longer term studies, up to 10 years, shows sustained benefit of the response after 10 years of doing the surgery. The patient selection for DBS is very important. We should know that patients with younger age responds better. Patients with no comorbidities responds better. Patients, is there a cutoff of score? For example, patients with BFM above a certain figure might be a candidate for surgery, or below it is not. We do not have that cutoff, but whenever the patient is medically intractable and his movement disorder interferes with his activities and daily living, so he is candidate for doing the DBS. What I'm going to do over the next few slides is to walk you through the steps which we do in order to perform the surgery which we do. First step happens even before the patient is admitted into the hospital, which is the targeting. We have many methods of targeting. First, the indirect targeting, which we know that we perform an MRI or a CT. We cannot see the actual nuclei, which is the GPI, sometimes the STN in these MRIs or CT. But we know that what is the relationship between our targets and landmarks, which are evidenced like the anterior commissure, posterior commissure. Then more recently, with advanced with the advance in the quality of the imaging and the more advanced equipments, we can see the STN in the MRI, and we can see the GPI in the MRI, and so we target this nuclei under vision, which is called direct visualization. So we choose which spot we want to implant our device in. Then after choosing the target point, we have to choose the entry point, which means where are we going to enter the brain from. This entry point should take us to trajectory which avoids sulci or ventricles or subependyma or important blood vessels in order to decrease the incidence of hemorrhagic complications. So this slide shows what exactly we do in the day of surgery. First, the patient goes into the OR and fix what we call the stereotactic frame. Sometimes it's done in the OR, sometimes it's done in the patient's room. Then we go to the CT scan and do the stereotactic CT, which means CT with the stereotactic frame on. Then the third step is that we merge the stereotactic CT with the plan of MRI, which we did previously. Then we go to the MRI and start the actual surgery. Go to the OR and start the actual surgery. The first electrode which enters the brain is microelectrode. It is a very, very small electrode which functions to detect or record the firing of structures along the trajectory which we have chosen. This is called microelectrode recording, and it serves to improves the accuracy and confirms what sort of physiological conformation of our anatomical target. Then we fix the final lead into the specific nucleus, and then fix the device to the skull and put the neurostimulator or the battery. Well, the complications of the DBS, it's very, very rare, but it is there. The most serious or of concern of them is the hemorrhagic complications or infection. So the patient must know that these complications are very rare, but that is there, and the patient or the family has to accept that this is a surgery, this is a brain surgery, and he has to know that very rarely a patient could have strokes or the serious side effects, but this is very rarely. Well, this is a patient which I think has DYT1 dystonia. She didn't have genetic testing, but we can see that she started by the twisting of her right lower limb, then extended to the right upper limb. She was 8 years old on the time of doing the surgery, and she was unable to walk alone. She has to walk supported. You can see that the right lower limb and the right upper limb had this sort of dystonia. She has a sister which has dystonia, and she has a brother which has dystonia. And this patient received, this is the stereotactic frame we are fixing before surgery, and this is the planning. And this is the patient after doing surgery. This patient did peridotomy, not deep brain stimulation, but the results or the outcome of both surgeries are almost the same. The difference between the results are of other things than the clinical outcome. Well, this is another child with segmental dystonia. He has cervical dystonia, jaw oromandibular dystonia, jaw opening, and right upper limb dystonia. The patients performed surgery, deep brain stimulation, peridotomy, then deep brain stimulation, and he has improvement in his jaw opening dystonia. He still has some right upper limb dystonia, but he did much gain benefit from the surgery. This is another patient who has had progressive childhood onset dystonia for 8 years before she presented to us, limb dystonia, cervical dystonia, and trunk dystonia. And she did deep brain stimulation, and she showed very, very good improvement after surgery. Well, the DYT28 dystonia is a new entity which has been described very, very recently. It has march, which is quite similar to DYT1 dystonia. It starts by lower limb dystonia and then moves caudocranially, and it sometimes has some associated features like short stature or specific features, or sometimes speech abnormalities. This study, which was done 2 years ago, describes a very large series, 53 patients with DYT28, a genetic mutation, and 18 patients of those 53 patients had deep brain stimulation. The mean age of patients with deep brain stimulation was 11 years, and follow-up up to 22 years. 22 years because some patients who did DBS 20 years ago were tested now positive for this gene. The outcome showed significant improvement after 3 months, or even after 6 months, or even the long-term follow-up after 20 years. The improvement of DBS was still there and sustained. This is our patient. He had DYT28 dystonia. I couldn't find much videos, but this one, we can see the characteristic facies and the, not microcephaly, but his small dimensions of his skull. And this is the patient just in the time before surgery, in the morning of surgery. He almost couldn't speak, and he was wheelchair bound, and he was progressing in the three or four months before doing deep brain stimulation. The patient performed deep brain stimulation. He was tested positive for DYT28 gene. This is the device of the deep brain stimulation from the entry point going exactly into the GPI, or the globus pallidus internus. and the patient after surgery, he showed improvement. He could walk. I couldn't find much videos post-operative, but those two pictures show that he can use his hand properly. And this 1 month ago, the surgery was done over 2 years ago. This is 1 month ago, and the patient could use his hand. He was performing very, very well in school. Well, the future of deep brain stimulation is plotting new techniques in surgery, and also developing new targets in different dystonic disorders. The conclusion is that the patients with generalized primary dystonia seems to have the best response to GPI DBS or pallidotomy, in contrast to outcomes for DBS for secondary dystonias, and that multidisciplinary approach is specifically essential for dystonia patients. And more research to gain more knowledge about different types of genetic dystonia and their response to different treatment modalities, including deep brain stimulation. Thank you.
Thank you, Professor Zeiad Yossry. في أسئلة دكتورة هدى؟
عفوا. هو طبعا ما فيش ايج كات اوف. في ستاديز على اطفال اتعملت لهم deep brain stimulation up to 3 years old, as young as 3 years old. احنا اقل سن عملناه كان 7 years old. But it's more of the configuration of his skull and the development of his skull more than the year as the age as a figure. But if his has well-developed skull bones in the CT with bone window, we can perform surgery. We ourselves did 7 years old, but there are reports in the literature as young as 3 years old.
سؤال تاني دكتور زياد، حضرتك بتتكلم كله على البرايمري ديستونيا. احنا مشاكلنا في الاطفال يوجوالي السكندري للجلوكوستاتيك اسيدوريا، سكندري للكارديكترس، ودي مرعبه. حضرتك كان الامبريشن بتاعك على ان الاوتكم بتاعها از امبريدكتبل، مش كده ولا؟
هو طبعا الاوتكم الكونسيستنت بيبقى في البرايمري ديستونيا. في السكندري ديستونياز ابارت فروم حاجات قليله زي التارديف ديسكاينيزيا او التارديف ديستونيا او البيكان. التارديف ديستونيا والبيكان responds very well to deep brain stimulation, but apart from those two types of secondary dystonias, the outcome is unpredictable. Sometimes even it is unpredictable. We had to perform the surgery in the end because the patient does not show any improvement and doesn't have any other chance. So even a 10 or 20% improvement would be beneficial to that patient.
سؤال تاني بعد اذنك دكتور زياد. ميرسي خالص على المحاضره الجميله. نفس سؤال هدى او قريب منها، هل ان احنا ما نقدرش نستخدم الدي بي اس كبالياتيف في عيانين البيكان مثلا بالذات؟ انا شفت كذا بيشنت dying from status dystonicus we cannot control, especially مش عارفه يمكن عبير اللي قالت التونج بيطلع بره وبيبتدي بايتنج وبيعمل obstruction للاير واي. it's very difficult. فهل ان انا من حقنا نستخدمه كبالياتيف تايب اوف ثيرابي؟
والله يا فندم هو بالنسبه للبيكان هي مش بس بالياتيف، هي يعني it is some sort of therapeutic and it leads to very good response after deep brain stimulation. We ourselves performed 2 surgeries for PCAN patients, and one of them did very, very well. The other patients, they were brothers. One of them improved very, very well, and the other improved, but not as his brother. So it is not just palliative. With patients with status dystonicus, sometimes it is in these patients a palliative measure, because those patients, the DBS might stop the dystonic storm they are in, but it does not cause functional improvement, for example, or sometimes in the literature you can find some sort of improvement, even more than the baseline, but it can be palliative in patients with status dystonicus.
فضلك هو سؤالين. السؤال الاول، الجهاز لما بيتحط بيحتاج مونيتورنج معين زي الباكلوفين بامب ولا حاجه، ولا بيتحط ويتساب خلاص؟ السؤال الثاني، انا عارف ان هو الديب برين ستيميوليشن دخل في التامين الصحي، براكتيكالي بيتعمل ولا لا؟ ولو ما اتعملش في التامين التكلفه بتكون قد ايه؟
اولا هو الجهاز بعد ما بنعمل له امبلانتيشن بعديها باسبوع، احيانا اسبوعين، احيانا شهر، بنعمل تيرنينج اون للديفايس. في اول 3 شهور بعد السيرجري المريض بيحتاج بروجرامينج سيشنز كل اسبوعين كل 3 اسابيع لحد ما نوصل للبارامترز اللي بتحقق للمريض احسن بنفيت. بعد ال3 شهور دول عاده البيشنت يا اما بيروح فور ريجولار فولو اب فيزيتس، روتين فولو اب فيزيتس، ساعات بيختفي خالص ونشوفه بعديها بسنين لما يكون الباتري او نيورو ستيميليتر البطاريه خلصت وهتحتاج تتغير. تغيير البطاريه ده بيبقى يعني سنجل داي بروسيجر وحاجه فيري سمبل، نوت يعني ذات لارج اوف سيرجري يعني. دي النقطة الأولى. النقطة الثانية هو فعلا دخل التأمين الصحي. احنا عملنا أكتر من 10 حالات على نفقة التأمين الصحي، فعلا it is practically done. وعندنا ويتنج ليست الحمد لله لمرضى التأمين الصحي. والحاجة الأكتر إن هو من حوالي في الشهر اللي فات بس دخل كمان على قرارات علاج نفقة الدولة. المريض الأول مريض اتعمل له القرار وجات له الموافقة، لسه ما اتعملش بس يعني دخل كمان تبع قرارات نفقة الدولة، ودي يعني هيوج ستيب. تكلفة السيرجي لمريض بيعمل على حسابه خالص very expensive طبعا. بتوصل بتبدأ من يعني ثمن الديفايس لوحده تقريبا 600,000 جنيه، ثمن الديفايس لوحده. على حسب بقى المستشفى بتضيف تكلفة المستشفى.